everybody, or good afternoon, or good evening. It's Gord Garner here at the Conversations of Substance podcast. I'm here with Dr. Kim Corace, longtime colleague and friend of CAPSIS, and we're here today to talk about a whole bunch of things around accessing services for mental health, substance use health, and addictions. And hi, Kim. Good morning.
Good morning, good afternoon, and good evening. It's great to be here, and I'm actually really delighted. I've seen all of these podcasts before, and anyway, what a great venue.
Great. And so I wanted to have this conversation with you, Kim, because as you know, we're trying to get things sorted out so that the barriers to care are removed, and at the same time, make sure people get all the care they need. So how do you think that works, and what's some of the language you think we need to understand? So, like, I don't know, what's integrated services mean when you're talking about integrated services?
Yeah, and I think that's really important because we throw these words around. What do we mean by integrated? What do we mean by coordinated? What do we mean by collaborative? What do these things mean, right? And so often, if we look at the literature, and also if we talk to persons with lived expertise or people in various healthcare professionals, I think what they think often of integrated is not having the silos that we typically have had. Mm-hmm. So as we know, mental health services and substance use health and addiction services have been siloed. Physical health services have been siloed for that, almost that social services, psychosocial services, and really need to understand a person as a whole person. So by integrated, we mean breaking down those silos, which is often, those are your barriers to access. People come with complex needs, but are they supposed to go to 7, 8, 9 different doors that they can't find?
Well, exactly, and at the same time, if I don't have complex needs, can I still come to the same door?
Exactly.
And so that would be like step care coordinated access.
Yes, and how do you know if you have complex needs?
Well, and why would I wait for complex needs before I ask for help?
You got it.
So let's walk this through then. So I'm out here in the world, and I'm not sure what's wrong, but things aren't going good for me. Mm-hmm. And I just wish there's somebody I could talk to. So I reach out, and there's a thing called coordinated access. Mm-hmm. What happens next?
And that's how simple it needs to be. First is that you know where to reach out. The biggest barrier, right, is people don't even know where to go.
Yeah.
They don't know who to talk to. They don't know where to go. And people, frankly, they get more unwell or experience more problems while they're waiting to figure out where to go, or they don't know if they're sick enough to go reach services, or maybe they're too unwell to go for services.
Those are the two stories.
That's what I hear.
You're too sick for us, and you're not well enough for us.
Yes, or you have so many problems and we don't have an integrated system, so we can't help you.
Right, and for me, is integrated means that everyone's going to go to the hospital, or does it mean that everyone I get help from is going to talk to each other about the help they gave me, and I get to be a known quantity? Can you explain that to me?
Exactly, and well, I mean, you know the answer when you ask the question, Gord. So, and that's the thing about silos. It's not just the silos between the treatments that are offered or the care that is offered. It's the silos between the people who provide that care. Yes. Breaking that down. Yes. People are whole people. Right? You can't break people into a part with, this is the compartment just for your mental health, or this is the compartment just for your substance use health, or this is the compartment just for your social determinants of health. This doesn't make any sense. That's not how people work. Yeah. So how do you so when we talk about integration, it's at the service level, it's at the provider level, it's at the condition and care level, it's the prevention level as well. Yeah. And it's bringing people together to work together for that person and meeting their needs wherever they are at in their journey. And I think the other important piece to that, in terms of where they get the help, needs to be help in the most appropriate setting, that's as close to home as possible, that meets what the person is looking for and meets their needs, right? So is that a hospital? Is that a community? And does it have to be either or? Or is it really about various settings with various expertise, the community expertise, hospital expertise, peer organization expertise, right? Yeah. Coming together with the person, and that's what it's about. How we're not just integrating services, we're integrating across providers, across organizations, across settings for people.
So if I came back 5 years later and said, hey, I got problems again, someone would know I'd been there, someone would know where I've been, someone would know where I've had success, someone would know where I didn't get to, and someone would have that, and I wouldn't have to pretend I'd never had a problem before, and they wouldn't pretend they didn't know me.
And that's what we hear over and over. Do I have to start over?
Yeah.
Am I at, did I make it around the board, or am I starting all over again, right?
You know, if I go to a certain hospital in town, if I was having a recurrence, the big flag would go up in the hospital that I'm a drug-seeking former patient. It wouldn't tell you I'd been to 10 treatment centers. It wouldn't tell you I had a period of long-term health. It wouldn't tell you that I'm familiar with the struggle that I'm having.
It doesn't tell your story.
Huh?
Mm-hmm. And one of the beauties of what we've done in the work, Gord, that we've worked together on for coordinated access is also those shared, this may not sound as exciting as these other words, but the shared health systems and the shared information systems.
Yeah.
So, and that's another key part of integration. How do you integrate the knowledge of where you've been and where you're going and who you're working with? And how do you do that without a shared health system?
And how do I do that with a GP? And how does my GP begin to ask the questions about my mental health? How's your head? How's your body and aches and pains? And how's your substance use? All right? As a normal conversation. Why? Well, 78% of us over 15 in Canada use substances. So why isn't that question asked? Well, because they don't know what to do with this. And I don't know. Is it just if I'm really, really sick, or because I'm not sure?
And the issue of not knowing where to go or where to refer someone, it's, how does that help those folks who are care providers, like your primary care provider, try to say, hey, we want to be able to help you work on your substance use health, the concern that you have related to your alcohol, the concern you related to your drug use. But if there's no easy system to get you there, what do I do?
Why?
Or what if I'm used to sending places and each place says no? And you hear from one of our other colleagues, it's the throw it to the wall and see what sticks. Yeah. Is that the best way to get care?
Well,
whatever's first at bat? Well,
and structurally and systemically, is it the best way to be able to assess what cares are needed in our communities, in our provinces, in this country, by having all these inefficient lists, and I'm on 10 lists, I'm waiting for help. I'm not getting off 10 lists because none of them have called me yet. When someone calls me, I'm not doing that well, I didn't really call the other 9 and say I'm okay now.
Exactly. And you take whoever comes first. And, you asked at the beginning, we need to move to a coordinated access to get people to step care.
Yes.
And when we bring systems and services and providers and experts from across all sectors together, then we're actually able to match people based on what their needs are, what their goals are, and what are some of the services that may best be matched to do that in the most appropriate setting with, hopefully, the least amount of intensity as possible is needed.
Well, and someone said to me just the other day, and it's kind of tragically sad, is that like I get the minimum service until I fail my way to the services I need? And I had to say no. It means you skip all the steps of the services levels you don't need and get to the level you do need, whether that's the first door or whether that's the 7th door. It's not an experiment to see, to keep you away from the service you need. It's actually that those complex services are received by the people that need complex cares, and that we don't have high-cost, complex services at the front door screening people out for not being ill enough.
Exactly. It's about matching. It's about matching on service to need rather than precluding somebody from getting something that they do need. And right now, without step care, without coordinated access, without looking at service matching, people are basically getting whatever they can find and what's available. But is that the best thing for them?
Yeah, absolutely. Well, and people that need inpatient care and client care are finding wait lists, and people offering outpatient care are finding capacities. And it's like, everybody doesn't need everything. And I think the most devastating moment for everybody I've talked to, and I know you've met thousands of people over the year, and so have I, and they all have a story about the day someone told them they were at the wrong place. And often, unknowingly, the term, "we don't serve people like you here," has come out.
Which is interpreted of, we don't want you, we can't help you, good luck.
Yeah.
Oh, the stories. And I think that was one of the key impetuses, right, for the work that we've done together with coordinated access and make it easier to take the guesswork out of care is no longer you're told you're at the wrong place. And that's what you've said, Gord, right? You're no longer told you're at the wrong place because this is the place where we can connect you to the numerous providers for the care that you need.
Yeah, you know, and it's, I don't know any industry, any social enterprise, anything that isn't about connecting people to what they need and what they do, right? Mm-hmm. Except this part of the healthcare system has been splintered for so long that my funding model says I can serve this population with these concerns and I can't take care of anybody else. And I'm so busy doing what I do, I can't stop and talk to you. Mm-hmm. So it really isn't built for you. Mm-hmm. And it's this mystery, right?
Yeah.
It's great mystery. You know, I was struggling a few years ago and I Googled detox and I got all these tea recipes, you know. And it's like, you know,
now what?
Now what? The tea's
right?
not going to work for me.
I know.
And so what, yeah, so this idea, and then again, so emergency, what if I'm in trouble, mm-hmm. right?
Well,
what happens?
And the way we've done the coordinated access work that we've done together as well, where, you know, have two-way linkages and some integration with crisis and services, it isn't a crisis service, right? Yes. There are crisis and emergency services, and that's where people need to go and seek out those services when they have a crisis and emergency. However, then what? Yes. I think what we hear from some of our colleagues who actually sit on our Access MHA or coordinated access work with us, right, who work in emergency services say, okay, so when the crisis or the emergency, you know, plateaus, then what?
Yes. Yeah. I think the phrase that someone actually has on a desk out in Nova Scotia was a direct quote from one of our videos, is they seemed to care that I didn't die, but they didn't seem to care if I lived.
And, you know, I think this is where access, you know, coordinated access to services come in, are those linkages back saying, okay, so how do we connect people to get the ongoing services they need, the community, with peer organizations, maybe they need other, you know, more specialized services. How do they get that once that's over in a reasonable way?
Yeah. And I want to get to the fascinating but boring part about data.
Oh, I was hoping we were going to get there. I'm like, if not, I was going to interrupt. And that's the other thing. How do we know what the system needs if we don't understand the population we serve? And that piece has been restricted again within the very silos that have been part of the frustration. And so I got a note from a good friend and colleague the other day about you know, how I used to challenge them on their success because it was seen through the lens of the silo, and it was a true story right up until you broke out of the silo and realized it wasn't a true story. Agencies, organizations, the pillars of tracked data that supports their work, and the exclusion of those that don't fit their data and their criteria are lost. And now we have a portal where we're getting folks who didn't get to the other places, didn't qualify, who can just reach out for help. And tell me a little bit about what that looks like. Well, we get back to integration. If we had only collected data on people seeking substance use services, health services, or people seeking mental health services, or people seeking housing services, and just asked about that one thing, we're going to know, as you just said, a lot about that one thing.
Yes.
The way that we've done this in the work that we've collected together, Gord, in terms of coordinated access, was broad and integrated. So because of that, we know the vast majority of people, the people that we're serving, are coming with more than one problem from more than one sector, right? Yeah. As typical. So most people will experiencing an anxiety problems, you know, related to their anxiety, problems related to their mood, and problems related to substances. Yeah. Concurrently.
There you go. Let me ask you a question about that, though. Does that mean I have to get simultaneous treatment from everybody at the same time, or can work on my health issues concurrently And I've got a counselor here, and I talk about this with them, and I have a counselor here, and I talk about that with them, and they've got an expertise in this area, and they get an expertise in this area. Or do we need to have one person with all the expertise? Does that drive up the cost system and underutilize some of our existing resources? What are your thoughts on that?
So I think there's a few different types of way people get care. There's sequential care, and that says maybe you'll talk to somebody about your substance use health, and then you'll seek your mental health services when that is done. But that...
I'm not a fan. Not a fan.
Well, neither's the research, so that's good.
That's good.
Good, Gord. And that doesn't actually pan out very well, because when are you ever done, and when do you ever meet the requirements, and what does that really mean? So
Yes.
in actuality, then there's parallel, which is, you'll get your mental health services from the mental health service world, and your substance use health services from those working in substance use health, but those services aren't actually connected. So
they need to be integrated.
So that's the third one, which is the integrated,
Yes.
whereby it's not necessarily the location. And that's what you're saying. Do we all
Yes.
do all the providers have to be in the same location? Or is it about providers working as a team for the client, with the client,
Right.
even when they're not in the same location? And that's the power of that, right?
Yes.
So it's about bringing those services together, and it's also ensuring that folks have the, if you look at different types of, abilities or expertise to provide concurrent, you use the word concurrent disorders, so concurrent treatments.
Yeah.
Does everybody need the same level of expertise, or can people at least have the, concurrent disorder capability?
Yes.
Right? As opposed to everyone having this, high level expertise, and that gets to your thing about the relying on and using the folks who are existing in the system, right? Because as you said, they're already there. Wouldn't it be very inefficient if we say, oh, we need a whole new workforce?
Well,
It's about supporting the workforce that you have, because we have a very talented workforce, right? So
Yeah.
how do you support that workforce to work together, to integrate, to work as a system, and also to have the level of concurrent disorder capacity that they need?
Exactly. And complex care for me is over here somewhere, and has a cost model that would be appropriate to the complexity of the care that's needed.
Yeah.
But becomes extremely harmful if that cost model moves upstream where it's not needed, and all of a sudden becomes a barrier to care.
Exactly.
And so, as we create this opportunity, we're going to have more people asking for help when they don't have to have self-diagnosed criteria to ask for help, and barriers are removed and stigma is removed. But those folks are not needing, for the most part, this. This is a small population.
Yeah.
But we know from some studies in the States that the most, around substance use, the most healthcare, long-term healthcare cost outcomes are not from people with disorders, they're from people who don't have places to talk about their management of their substance use and their health around their substance use.
Yeah. And exactly, and the point that you're making in terms of what people, where they are in that continuum of care, which is what you've got going on here, right?
Yep.
Is your continuum of care, that's what you have. We still want all folks providing care across the continuum of care to be able to ask questions, as you said, about substance use health, and not just be in the mental health silo, or vice versa, right? We want people to be able to still provide
Yes.
and have some capacity
Yes.
to provide that kind of care, but it doesn't all have to be at the enhanced specialty level, because that isn't, the majority of the population don't need that level of care.
No, but the people that do absolutely need that.
Oh, absolutely.
Right? And that has to be recognized, and we're seeing a lot of folks in those situations with no care and bumping against a system that has no room for complexity, only has room for acute moments of the complexity.
Yeah, and and I don't say this lightly, but the silos in our healthcare system harm people.
Yes.
They harm people.
Yeah.
And people aren't able to get the care, or when they get the care, it may not be the kind of care they need.
And I want to stay there just for a moment, because that's a place that's hard to talk about, because people in the healthcare system have dedicated their careers, their educations to helping people. And so we're looking at a structural problem, and a structural
Oh,
recognition
absolutely.
that needs to be looked at and saying, you know, because everyone wants to come and fix the box that's not working, and so they get the box fixed. But if you got the wrong box, there's no way to get it to
This
work.
is a system level issue. I have never in all the years I've been in healthcare met a healthcare provider who doesn't want to go 110% for the person that they're serving. Ever. Never have, and I doubt I ever will meet that person who doesn't want to do that.
Right.
Right? It's not that. It's how our systems and structures are organized in a way that perpetuate
Yeah.
and reinforce silos. And that's what needs to change. And I think there's momentum for that, Gord. I have to say, first of all, I think the work we've done in coordinated access, it's inspiring to watch these organizations and agencies and people come together.
Yeah.
Right? I mean, for you know, to not just about access, but also to ensure our equity-seeking populations
Yes. Absolutely.
have access, right?
Yeah.
Not creating access for some and not for others, and recognizing the journey it takes to get there. And I think if we look at some of the work happening in Ontario and Canada, a lot of focus on integration, bringing that together, and breaking down some of those systemic and structural silos, from everything to how we're funded, to how we collect data, to how we count.
And I'm going to end up at the front door again, and because I'd like to finish there, Kim, is that integration, that coordination has to have that opening that says, call us if you're worried about yourself.
Mm-hmm. Call us if you're worried about your wellness.
Don't worry if you know what the answer is, and don't have some idea that you have to be this to be that. Just call us, and we'll sort through what can help. And I know because in the systems and the funding tracking, that access and that piece isn't considered a health service, but we know from the families and clients that we all know that moment that we pick up the phone or we send a text message or we walk in the door and somebody says, oh yeah, we're so glad you came. Right? That is a health benefit.
Yeah,
Right.
Kindness, welcoming, compassion.
Right? You know, anybody experiences those things in their lives, even for a moment, can tell you what that moment was. And when people are struggling and uncertain and unsure, if in fact there's hope for them, if in fact there's help for them, if in fact someone cares about them, if in fact they can even ask the question, that's the required response for us as a society and as a system of healthcare. And I'm so proud of the work you've led, the work I've had a chance to do with you. And I'll never forget the first meeting of the Client and Family Member Committee here, when of all the people in the room, no one asked us why we were doing this.
No.
Nobody. And so there's a big question of why we haven't done it in the past, and I believe, Kim, that I know the answer to that, and I know the difference. And can I talk about that for a second?
Sure, it's absolutely.
Well, it's not supposed to be my podcast.
I know, but
I'm not a great moderator, right?
we get to do the work together. Go for it.
No, let's go. I'll volley back to you. What do you think? Why did we succeed this time in doing what has never been done before?
Few things. Our core and guiding principles has always been, you know, not only for and by clients and families and peers, but led by. And I think the work that we've done with the coordinated access work and Access MHA has become, from what I looked at, and watching it evolve too and grow, this co-leadership, collaborative governance structure that we have with clients and families and peers. Yes, there's a committee, but it's not voices at a table, Gord.
Yeah.
Right? It's not voices. It's leadership, it's driving, and I think that's made all the difference every step of the way.
And I'll always come back to this piece that empowerment comes through the relinquishment of power by others. And so I look to our community partners and to yourself and to all those who agreed to empower clients.
Well, I can't imagine that we would have been successful otherwise, really.
Well, the evidence says you're right.
Oh, even better. So, and watching that grow and evolve from, you know, it was new. It was a new type of model, right?
Yeah.
So I think obviously engagement and leadership may not be new, but the collaborative leadership structure between various agencies as well as client and family leadership, that was something new frankly, to negotiate and to understand and to figure out as we went. And I think what it's evolved into is something richer than we could have imagined.
Absolutely.
And I'm really, really, really quite honored that I had the opportunity to learn from you, from Michelle, from other of our client and family leaders to help guide the way and to guide our philosophy. If you think about it, the philosophical guiding principles, our core values, mission and mandate, that all lives with you guys.
Well,
right?
Again, you know, someone said to me sometimes, some of these things don't sound like rocket science. It's just never been done before, right? So it's pretty special. And so let's keep on going. There's lots of stuff, and I know we're both working on standards of care coming up, and so you know it begins with caring. It begins with caring. I like that. Well said. It does. I'm going to shut us down now. Thank you. Great to see you. Good to see you, and thanks for having me here in this exciting discussion. Well, we barely got the lights changed in time to match. Exactly. we do the best we can. All the best, everybody. Okay. Thank you. Bye-bye.